Hello everyone, today we'll be talking about hypovolemic hyponatremia and how to manage it. Let's go over the outline of treatment and then we'll discuss all these points one by one. Step 1 is to correct the underlying problem, that is your volume status. Keep the rate of corrections between 6 to 8 milliequivalents per day. Expect these patients to have rapid correction once volume status is optimized. Therefore, watch their urine output closely and understand how to use D5 and dDAVP to correct the overcorrection. So if you understand, the hypovolemic hyponatremia is caused because of low intravascular volume status. This stimulates your baroreceptor reflex and stimulates the production of ADH. And the ADH production will result in aquaporin molecules, and that will result in more free water absorption, and that would result in higher urine concentration and lower sodium. We already talked about how to diagnose hypovolemic hyponatremia, but let's refresh it. The first question you ask is there ADH in the system? And you check your urine osmolality. And in patient with hypovolemic hyponatremia, since these are intravascularly dry, therefore they have high ADH, so their urine osmolality is high. Next question is, what's your intravascular volume status? And for that, you check your urine sodium, and in these patients, the urine sodium will be low because these are intravascularly dry. Lastly, you check your ECF status. That means if there is an edema or ascites, that means you're extravascularly dry, and combination of these three will tell you that you are dealing with hypovolemic hyponatremia. The first step is to correct the hypovolemia, and the rate of correction will depend upon the hemodynamic instability. If you're in hypotension or shock, you have to give bolus of normal saline as you would like to resuscitate them. If they are stable, you can use them as a continuous drip. Remember, the ADH response in hypovolemia occurs later, so if you don't correct the underlying problem, you may run into other problems like organ failures such as acute kidney injury. If your patient is hemodynamically unstable, you can give them bolus of normal saline or ringer lactate, and you correct the hemodynamics if your patient is fluid responsive. The question everybody is worried about is if these patients would overcorrect with saline boluses, and therefore a lot of these patients don't get any. So let's see how much 1 liter of normal saline increases your sodium in any hyponatremia. So if you go through our calculation as we did previously, your new plasma sodium has increased from 110 to 111 with 1 liter of saline. So as you can see, the increase is not much. If your patient is hemodynamically stable, you can start them on a continuous drip of ringer lactate or normal saline at 1 to 2 ml per kg per hour. Sometimes you do see the rate of correction can be rapid. However, understand that this rapid correction is not from the sodium in the saline that you gave this patient. This happened because you corrected their volume status and their ADH stimulation stopped, and now they are losing a lot of free water in the urine. If you understand that once the ADH production drops, so does the aquaporin molecules. Therefore, your free water absorption in the distal convoluted tubules drops as well. So you make a lot of urine with low urine osmolality. If you give saline, you are going to correct the baroreceptor reflex. Hypothalamus has got no reason to produce any more ADH, so you do not have any more aquaporin channels, so you lose free water in the urine. Your urine osmolality drops and your sodium corrects. Therefore, ask your nurse to call you if the urine output increase. This is possibly the most important thing that you have to tell them when you're dealing with hypovolemic hyponatremia. This is the time when the sodium is going to correct rapidly. And this is the time when you change your sodium frequency checks to every 2 hours. Sometimes this rapid correction will not happen if your patient has developed AKI or ATN. If the patient corrects rapidly, there are 2 steps to it. First thing is to stop free water loss in the urine, so give them dDAVP. And secondly, to lower the sodium to the target sodium, give them D5. 1 liter of D5 bolus will approximately drop your sodium by 3 points. And of course, you make sure that patient is not eating any more solute and has appropriate free water restriction. You have to understand one more thing, that dDAVP that you gave is going to last only a few hours, as its half-life is only 2 to 4 hours. So rapid correction will repeat itself once dDAVP wears off. Make sure that you schedule dDAVP every 6 hours to clamp the urine, and you can choose to add 3% saline to raise your sodium. Make sure that your patient is on free water restriction when using dDAVP. Correct the underlying volume status. Give normal saline or ringer lactate if hemodynamically stable, and boluses if hemodynamically unstable and fluid responsive. Expect the patient to have rapid correction once volume status is optimized. Therefore, watch the urine output very closely and make sure that you tell the nurse about this. Rapid correction is heralded by increased urine output unless patient has AKI from prolonged hypovolemia. Make sure that you understand the use of D5 and dDAVP in these cases to correct the overcorrections. And you can schedule your dDAVP to slowly correct your sodium to normal values. Your rate of sodium, as in any hyponatremia, should be between 6 to 8 milliequivalents per day. Thank you.